Thank you, Shripriya. Good evening to all. Happy to see you again. Today we are going to learn about wound management. You might have seen different types of wounds in your settings, but in palliative care we have seen two different types of wound. One is pressure ulcer. The another one is malignant ulcer. So today we are going to learn about the pressure ulcer. This session will be taken by Ms. Snehalatha Sureshan. She is a MSc nurse. She has around 6 years of working experience as a program officer. She was a former nursing lecturer in College of Nursing, Jaipur, and she has contributed a chapter in a book called Nursing Education and Technology. And also she has published a research article in European Journal of Molecular and Clinical Medicine. She did her 6-week certificate course in palliative nursing. And now she is working with us and she is a faculty. So Snehalatha, welcome and over to you.
Thank you, ma'am. Thank you for the introduction. Okay, so okay, so we will be starting with the session that is wound management. I would like to get this session as an interactive session. So I would like to get a vague idea about what do you mean by wound management. Anyone, please respond. No one is responding. Please respond. What do you mean by wound and how in your setting you are managing it? So with that idea, we can go forward.
Sister Alfonso, if you are trying to communicate, you are muted. Can we have the videos on, please?
Okay, Kalyani ji, can you respond?
Pressing, ma'am.
No.
Yeah, tell. Okay, in the comment box, it is Jaba Singraj has responded healing the wound and preventing of infection. Jyoti has responded preventing the wound from contamination and microorganism, reducing the worsening of the wound. And wound are injuries that break the skin of other tissue. Wound means injury to living tissue caused by cut, blow, or other impact. So yeah. So thank you for your response. You have got a general idea what does it mean. So we'll go today. We will be looking forward with pressure ulcer. Okay, so what is pressure ulcer? It is also known as decubitus ulcer or bed sore, right? So pressure ulcer is localized injury to the skin and other underlying tissue, usually over a bony prominence as a result of prolonged unrelieved pressure. So whenever in our palliative care setting, we have most of the person who are bedridden are usually occur pressure ulcer or bed sore, right? So the area where any unrelieved pressure, that is if a area, especially in the boning prominence, there is an unrelieved pressure in that area because of improper circulation, that will lead to the breakdown of the underlying skin tissues, right? So that will lead to pressure ulcer. So we can say that. So how we can manage that? So that is, if we will relieve the unrelieved pressure for a prolonged time, if unrelieved pressure is there, if we are going to move that person or change the patient's position, so that will prevent the bed sore, right? So simply we can say, what is bed sore? Bed sore is a localized injury to the skin and other underlying tissues, especially over the bony prominence as a result of prolonged unrelieved pressure, right? So next. So this is the image as it is shown because of the unrelieved pressure, especially in the heel area, right? So in the bony area, there is a pressure ulcer. This is the sacral area, especially when supine position is attained, the most prominent area or the prominent bone which is there in the sacral area will lead to the pressure ulcer. Right. So first we will look into the pathophysiology. Pathophysiology, that how this unrelieved pressure is causing bed sore, right? So as you can see in the image, it is a person is in the supine position, and the image below it is given that in the bony prominence area, because of the unrelieved pressure or the weight of the body, the bone is compressing the tissue, right? So when the bone is compressing the tissue, it will lead to like the mattress is below, right? So with the bone and the mattress in between there is a layer of skin. So that skin will be torn or teared because of that unrelieved pressure, right? So pathophysiology is saying that pressure for a long time, that will lead to collapse of the blood vessel. So we know that because of any pressure, undue pressure, that will lead to impaired circulation, right? So the collapsing of the blood vessel will lead to nutrition and oxygen and tissue perfusion will be impaired. So proper nutrition will not be getting in that surface area of the skin. Oxygen hypoxia will be there, that is there will be oxygen deficiency and the tissue perfusion will be impaired. So that will lead to tissue ischemia, that is oxygen deficiency will lead to the death of the cells and hypoxemia or even cell death, and that is because of the stress that like what we can say, because of that improper circulation, the skin will be stressed up and that will lead to breakdown of the skin. Okay, is it clear? Is it clear? Okay, thank you for responding, Jyoti. Thank you. Okay, so next we will go to risk factors. So why it is important to consider the risk factor? Why? Because in the palliative setting, we are not only dealing with the patient, we are dealing with the family also, because we are educating the family in order to look after the patient in the home setting, right? So risk factors are very important to understand how to prevent the bed sore. So first is friction. Friction, as we know. When you are seeing friction, what do you understand by friction? Any idea? Any idea what do you mean by friction?
Rubbing over the surface.
Yeah, rubbing the skin surface or the our skin is getting rubbed with the bed surface, bed sheets and all, right? So that rubbing will create a friction and that will lead to the tissue injury or skin breakdown, right? So friction is very important. So whenever we are telling a patient to move from, that is a bedridden patient to be moved from one place to another, or even when we are changing a bed sheet, right? So at that time we should not pull the patient, right? So what we have to do, we have to there is a proper setting that how to change the bed sheet. So these all education we have to give. We have to tell them how to change bed sheets and all, so that the friction cannot be developed. And also whenever we are changing the position, that time also we have to consider that the friction can develop, the rubbing of the surface can develop, right? So that because of that, the risk factor, that is friction, can lead to bed sore. And also shear mainly because of the obese patients and all, they are more prone to get like risk of getting this pressure ulcer, right? So what will happen whenever we try to, these are all interrelated, friction, shear and all. So what will happen when we will change the position of the patient, even the obese patient, the rubbing will lead to skin breakdown, right? So we have to tell them that these all factors, whenever we change the position of the patient or we are changing the bed sheet of the patient, we have to consider these factors. Then impaired sensory perception, mainly the trauma paraplegic patients, right? So they also have an impaired sensory perception also, so that will, or physical immobility will be impaired. So these are also a risk factor that will lead to pressure ulcer. Then altered level of consciousness, the patient's conscious level is altered. So the patient is lying in a single position, we are not changing the position of the patient, so that also lead to pressure ulcer. So these all factors has to be considered. Then fecal and urinary incontinence, the continuous exposure of moisture to the with the skin, that will also lead to skin breakdown. Okay, then malnutrition because of deficient nutrient, that can also lead to, that is which protein, like protein deficiency, right? So whenever the patient is not eating, even if we are giving fluids and all, protein is also considered, then only the wound healing will take place. So malnutrition can also lead to pressure ulcer. Dehydration, dry skin can also lead to pressure ulcer, right? Then excessive body heat, this is also we are aware, whenever the patient is in the like ICU, after that they are especially in the ICU because of AC and all, right? So the patient will be in contact with the bed surface, and they will be draping with the sheets and all. So the excessive heat of the body will cause bed sore, right? So that we have to consider as a main risk factor. Then age, advanced age is also because of improper nutrition, because of dehydration, that advanced age can also lead to pressure ulcer. Then what are the common sites of pressure ulcer? So as it is given in the image, the patient, first image is showing that the patient is in the supine position. So back of the head is more like more bony area, that will lead to pressure ulcer. Back, shoulder blade, lower back, elbow, heel. Then in the sideline position, either it is left or right, ear, shoulder, elbow, hip, okay, between the knees and ankle. So in order to prevent pressure between the knee and ankle, can you please respond what management in your setting you are following in order to prevent rubbing of the both knees together? Please respond. If a patient is in a sideline position, yeah, we can in between the knees we can put pillows, right?
Pillows.
Soft pillows, so that the pressure is that undue pressure can be relieved, right? Then in the follower's position also, lower back, sacrum, head, these are all, and the wheelchair, especially the paraplegic patients, they all, because of loss of sensory perception, they can also get a pressure ulcer in the lower part of the body, right? So, and especially if it is more wheelchair use is there, that can cause hip, lower back, shoulder blade, and even in the outer side of the back of the heel is more prone to get better ulcers, right? So these are the images whenever we see in our setting, what are the types of or the images which we are seeing, we have to identify what type of stage it is, right? So these are the images, especially in the bony prominence, it is more prominent, right? So these are again explained that what are the common sites, especially supine position, that is head, shoulder, elbow, buttocks, heel, toes. These are the more prone areas. The patient are prone to get bed sore, right? And this is the sideline position. So as you have said, in between the knees, there should be a pillow in order to prevent bed sore in the knee area. Then this is the semi-Fowler's position. So if like a patient who is more last stage of CA lung and all, they will be having very respiratory distress. So at that time, when we'll give a supine position, we have to be extra conscious about the sites where the bony prominent areas are there that can lead to pressure ulcer. Okay, so head, shoulder, sacrum, buttock, ischial tuberosity, and heel are the more areas where we the patient can get pressure ulcer. Then common site for prone. So mainly in like the patient who has bed sore in the sacral area, we can give them as a prone position, right? So prone position itself can give one more bed sore. So we have to be aware of that. That is, the common sites are head, elbow, chest, reproductive organ, knees and toes. This has to be protected. Okay, so this is very important. Next, that is stages of wound. Any idea what are the stages of wound? Please respond, then only I can know that you are also listening to me. Okay, 4 stages. Can you elaborate it? What are the 4 stages? Okay, so we will go to the stages of wound. What are the stages? First stage is, as you can see in the image, it is red and differently colored spot that does not blanch with pressure. So whenever we give a pressure, that will not be blanched, that is, that will not change. So that is non-blanchable erythema. Redness is there. So that mainly because of undue pressure or prolonged pressure in one particular bony area, that will lead to the stage of 1. That is only retained to the first layer of the skin, that is epidermis layer of the skin is only causing that pressure, right? So that is non-blanchable erythema. That is erythema is what do you mean by erythema? That is redness, right? So only non-blanchable erythema will be there in the first stage, right? Second stage, there is a partial thickness skin loss, shallow open ulcer into the dermis, and serum filled blister. That is, there will be a blister formation. Okay, so upper layer of the skin, that is epidermis, will be broken and it will be leading towards the dermis, right? So dermis will be breaking down, it will be red in color, there will be changes in the temperature also, and it will be an shallow open ulcer. Mainly it can cause blister also, that is, that will be water filled exudate will be there, right? So that is the second stage. See what I said. Okay, so that comes in second. Ulcer, that is blister formation is there. So that that blister, if it burst, then that whole layer will be removed up. So at that time, the second like this blister can be seen. That means it is second stage of ulcer. So we can see in the first image that already that layer, epidermis layer, has been removed and it is extending towards the dermis layer, right? Then third stage, that is full thickness ulcer, that is epidermis, dermis, all the layers has been, and it is reaching towards the subcutaneous tissue. That is next third layer, that is subcutaneous tissue will be involved. So that is and it also lead to tunneling. In the third stage, we have to be extra whenever we observe a pressure ulcer, we have to be extra conscious that it either there is a tunneling or not. That is a narrow opening or a passageway that can extend in any direction through soft tissue. That is either it can be tunneling, can be in the adjacent areas, that is nearby areas of the last areas of the ulcer, that will be tunneling towards the upper part or lower, wherever it is, there is a space in between, right? So any direction it will be there. So that narrow passage is called as tunneling. So that can be checked with a small stick with that, and we have to measure that also, how much length it is going inside, right? Then stage 4. Stage 4 is mainly exposed to the muscle and bone tendon. That is epidermis, dermis, subcutaneous, everything, every layer has been torn up, and then it has been exposed to the muscle and bone tendon, right? So this is the image. As you can see, the bone and the muscles are all exposed, right? Have you seen this kind of wound?
Yes.
Thank you for responding. Okay, next is unstageable. That is, we consider is at fifth stage. That is unstageable. That means there is an eschar formation. That is either it can be in the first stage, second stage, third stage. So when there is an eschar, that is blackish skin is there, that tissues are there. When we debride it, we remove it, then only we can see to what extent that pressure ulcer is. That is, we can identify what kind of stage after removing the eschar or slug, right? So pressure sore is unstageable if there is an unstageable when there is a scar or eschar formation on the top. When we remove the eschar, then only we can identify either it is a third or fourth stage, right? Then deep tissue injury. This is the sixth stage, that is deep tissue injury. Okay, so deep tissue injury means what? Because it is also a non-blanchable deep red, purple and maroon discoloration because of prolonged pressure or shear force that will lead to tissue damage from inside out, and it can be gone into directly into third and fourth stage. This is an important stage. This is a new stage which has been introduced, that is sixth stage, that is deep tissue injury stage, in which what happens, there will be red color will be there. This because of impaired circulation, there will be redness, or either it can be purple color or maroon color. Purple maroon color when it comes when there is a necrosis or any hypoxia is there, right? Oxygen deficiency in that area is there. So that will lead to, that is mainly because of what? Because of prolonged pressure or shear forces can happen. So that will lead to either that tissue damage will be identified into gone into stage 3 or stage 4, right? So that is deep tissue injury. So the stages are clear. First stage, second stage, third stage, fourth stage, and fifth stage, that is undifferentiable stage, and sixth stage is deep tissue injury, pressure injury stage, right? Is it clear? Okay, thank you for responding, Priyanka. Okay, next we will come to when we know what are the risk factors involving in the pressure injury. As a nurse, we have to know what are the assessment findings, right? What are the assessment findings we have to ask to the patient? What are the subjective data which we have to follow, right? So doctor and nurses must assess the patient's skin at each visit of the bedbound and wheelchair patient. Why we are saying a bedbound and wheelchair patient? Because majority of the patient who are bedridden and wheelchair using, they are more prone to get bed sore, right? So what we have to assess? We have to assess the pressure point areas. As image shown in the earlier slide, there are pressure point area in the supine sideline position and also in the prone position, follows position. So we have to assess the pressure point for any kind of redness or circulation impairment. Then we have to assess for the pain associated with the wound, what level of pain the patient is occurring, because in the second stage the pain will be increased, right? So we have to assess the pain associated with the wound, and also we have to assess for the location, where is the area, which area is more prone to, like, as we said, no, the more prominent area are more prone to get the bed sore. So we have to assess the location also, and also we have to measure the wound area, that is the width, the length, and the depth of the wound has to be measured. We have to identify what is the stage, which stage it is, either it is first stage, second stage, or the third stage, right? And presence of exudate, that is fluid filled, that pouches are there or not, right? So in the epidermis layer, so that we have to check for that exudate, because that removal of that exudate will lead to going into the third stage also, third stage, right? Or second stage. So we have to check for the presence of exudate, and also assess for the tunneling. That is very important. Please, can anyone respond what is tunneling? What is tunneling? Which stage we have seen the tunneling?
Stage
Fourth
third.
stage. Fourth stage. Hello, ma'am. Fourth stage.
Fourth stage. Okay.
A narrow opening or passage way that
Yes, respond.
can extend in any direction.
Yeah, very good. That can extend into any direction. So who all have not responded, I would like to show the slide again. That is in the third stage, after the full thickness ulcer, there can be formation of tunneling, that is narrow opening or passageway that can extend in any direction through the soft tissue, right? So this is tunneling. We have to check. This is very important, because in that area we have to be extra cautious that either tunneling is there or not, right? So that we have to look whenever we are doing a dressing, that time we have to note that is tunneling is there, either the tunnel is extending more into the soft tissues or not, that we have to consider it, right? Thank you for responding. Okay, so these are the assessment findings, and also we have to chart the findings. Finally, we have to chart it, what all findings we have got. So management. So anyone can respond, what are the managements you are doing in your setting for a bed sore?
Too early changing position.
Yeah, okay, change in the position. Thank you.
Okay.
Then,
Back care.
Air mattress. We provide air mattress.
yeah, assistive devices, we provided air mattress, water mattress, any of the things, right? Then
At sacrum region, we give patient that ring.
Ring.
Okay, what ring?
Oh,
Air cushion.
air cushion.
Covering it from the towards the abdomen, that kind of ring, right? Soft.
No, ma'am. Ring, only on that ring, patient can sleep supine position, and below the sacrum region, we put that round ring.
Okay. Okay.
Ma'am, you
Then
like bike tube.
okay.
Apply gentle massage to bony prominences.
Okay. Very good.
Care.
Skin care is very important. Then
We are giving back care to the patient.
okay. Back massage. Okay. Vinisha responded back massage. Okay, thank you for your response. So the management is always medicate patient for the pain before wound care. This we are doing or not. Whenever we do a dressing, we know that it is painful, right? So what we can do is we can provide a pain analgesic to the patient so that the patient will not get too much of pain while dressing, right? So always medicate the patient for pain before wound care. Then if it is the first stage, then teach caregiver to turn and excellent incontinence control, right? So we will teach the caregiver. Why? Because in the palliative setting, if a patient is paraplegic, right? So for a short duration, we will be assisting them. We will be teaching the caregivers about how to take care of the wound, right? So we will teach the caregiver to change the position every 2 to 3 hours. So that is very important. Every 2 to 3 hours, we have to tell the caregiver to change the position of the patient, and also excellent incontinence control, right? How we can control the incontinence? If it is urinary dribbling is there continuous, we can catheterize the patient, right? And also we have to take care of the catheter also, because it can lead to further infection, right? So we have to tell them how to do it. That so incontinence control, or either we can, if the patient is using diapers also, that is also more important. Jaba Singh Raj has said that pampers, yes, pampers, if the patients are using diapers, so we have to be extra cautious that we will put what we can say, a biolin we will tell them to use as a skin care, so that the rubbing of the surface friction will not lead to bed sore, right? So in the first stage we have to do this. Then second stage, cleaning and dressing with the normal saline. Second stage there will be more painful, so we can give the analgesic, and then we have to dress them with the and clean them with the normal saline. Stage 3, 4 and 5 are unstageable. We can do the debridement, because there is an scar formation, black skin, tough layer of skin will be there, which is dead tissue, right? So that slug we have to remove it through either debridement, that is through cutting that extra scar, surgical debridement, and we can use normal saline for cleaning the wound. That now how we can prepare the homemade normal saline? Any idea?
1 glass water, 1 pinch of salt.
1 glass water, 1 pinch of salt. Okay, if it is a 1 liter, then we can say them to put
5 glasses water and 5 pinches of
Ah.
salt.
Okay, so in that if it is an, like we can say 1 tablespoon for 1 liter we can use, and we can tell them to boil that water and then cool down it and cover it with a lid, so that that saline water will not be like spoiled up, right? So that we can tell them how to use the homemade saline, because the normal saline which is in the available in the hospital setting is costly also. They cannot afford everyday buying. So we will tell them how to make a homemade saline. And if there is an odor or infection, like it's suspected infection, foul smelling discharges is there, foul smell is there, so we can tell them to use metronidazole powder, or we can tell them to use metronidazole nebulization, so before the dressing, right? And to and also that metronidazole powder, what we can do is we can crush that pills and then put that powder, right? And also and that crushing should be in a fine powder, right? And to a gel lubricant, that is white petroleum jelly, and spread on the wound. So whenever there is an scar formation, so before doing the debridement, what we can suggest is we can put the biolin in that area. That is, biolin is a kind of Vaseline. We can put that, so that biolin will soften that scar and the debridement will be more easy, right? So that we have to look whenever we are doing a like management of the bed sore. And also debridement, that is pepapin, urea or ointment we can use. And mega heal mono silver colloid ointments which we can use is mainly debridase is also used to soften that scar areas or uh, hard areas. We can put the debridement or debrid ointment. And also mega heal in the red areas, because in order to promote the that muscle growth, tissue growth, okay, granulation tissues can be developed, so mega heal will be more helpful, right? So these are the management which we have to follow. Then charcoal under the bed will absorb the odor. So if any kind of big wound is there, so that is very foul smelling, so the patient will be having body image disturbance, right? So what we can suggest them is to keep 2-3 pieces of charcoal. That charcoal will be helpful to absorb the foul smell. Or avoid hypochlorite solution like povidone iodine and hydrogen peroxide, because it will cause tissue that skin irritation. So we have to tell them avoid these kind of solutions. And also surgery consultation has to be advised. So next image what it is showing is a charcoal what we can say dressing material which can be kept, right? Then negative pressure wound therapy, that is it is a sucking device which sucks any kind of pus and everything from that wound area, that can be put in that wound area. That negative pressure will be developed, and that negative pressure wound therapy can be more effective to remove any kind of pus or any what we can say exudate are more coming, oozing is there, right? So that can be sucked out. So this is also a management part, though that instrument is costly. So in the home care setting, we will be more in the palliative setting, we have to more focus on the cheaper part, right? But we should be aware about it. So how to make a normal saline, right? So this is the exact thing what we have to do. As I said in 1 liter it is 500 ml of water. So normal saline, we will take 500 ml of water and add 1 tablespoon of salt. So what we will do, we will boil them, cool it and keep it covered, right? So the only difference is quantity is 500 ml of water, that is 1 tablespoon. So if it is 1 liter, 2 tablespoon, right? And also wounds are not sterile, so the saline has to be clean, not sterile. So wound we consider it as not sterile, so we can put a what we can say, we can put the we can make a homemade saline. We can boil it, cool it and cover it with a container or a lid, so that it will be clean but not sterile, right? So next, how to prepare gauze, right? So how we'll prepare a gauze? Any like cotton and gauze, it's also costly. So what we can suggest them is take an old cotton saris or dhotis, cut it into square and steam them for 1.5 to 1 hour, and may impregnate them with Vaseline or liquid paraffin. So where we can tell them how to make a gauze. So it should not be dry, right? So in order to avoid drying, we will suggest them after sterile, cutting it and steaming it, it will become sterile, and we will put a Vaseline layer on the top so that it will not be dry. So whenever we put that in the wound, it will not stick, right? And when we put a dry gauze, what will happen? The changing in position, everything will lead to rubbing of that gauze with the wound, right? So that can bleed, right? So in order to avoid that, we will suggest them to use a single layer of Vaseline or liquid paraffin, right? Then prevention of bed sore. That is, as you have already said, that when we can manage the bed sore, so we have to consider educating the caregivers how we can prevent it. So we know that the patient is bedridden for 2-3 days. Now the bed sore has not developed. So we can use the preventing strategies. That is, first one is change the position. So we will suggest them, if the patient is bedbound, 2 to 3 hours for the bedbound patient. Every 2 to 3 hours, there should be change in position. Then every 15 to 20 minutes for a chair bound patient, that is wheelchair patient. We have said that wheelchair patient has also be considered because they are also more prone to get bed sore. So we will tell them or suggest them to change the position every 15 to 20 minutes if they are using a wheelchair, right? Then manage incontinence. How we can manage incontinence? Like catheterization, we can check whether any kind of leakage is there or not. Diaper, if they are wearing, we can tell them to avoid the extreme moisture. That is, timely changing of the diaper is also good. Why? One diaper we have put it in the morning and till night it is there, right? So what will happen? All the urine will be connected and it will become more moisture. That surface will be come in contact with the skin and that moisture will lead to skin breakdown. So we have to manage the incontinence also, and also we have to give special surfaces, as we have said, assistive devices, that is air mattress, water mattress, pillow and cushions, right? These are the images, that is air mattress, water mattress. Okay, and along with that, nutrition, hydration, and exercise. Why? Nutrition is important because once the bed sore is developed, or if it doesn't develop also, if lack of protein will lead to thinning of the skin, right? So that thinning of the skin will lead to and it will rub with the surface, that will lead to bed sore, right? So inadequate nutrition can also lead to bed sore. So in order to prevent the bed sore, we have to suggest nutrition, that is extreme protein rich diet. Okay, protein rich diet we have to suggest the patient, and also hydration, that is drying of the skin can also lead to bed sore. So we have to suggest them to drink a ample amount of liters of water per day, and also exercise, that is range of motion exercises. That is also important. Why? Because of immobility is the main reason why the patient is getting bed sore. So if the patient is moving his hands and elbow and everything, the exercise and mobility is there, so that will be causing improved circulation to the skin and the bed sore will not develop, right? So hydration, nutrition and exercise, along with that assistive devices, management of incontinence and change in position is very important. Then massage, that is the dry skin, we can prevent it by massaging the surface, or we can give the skin care with liquid paraffin or white petroleum jelly. And also this is also very important, that is wrinkle free bed. Why wrinkle free bed we are saying is that if wrinkles, that is extra layer of bed sheets will be there in the bed, what will happen? The patient will be lying on that will be pressing towards the bony prominence, that area there will be impaired circulation, right? So that wrinkles should be avoided in the bed. It should be like straight enough that the wrinkles will not be there, and then we can prevent the bed sore. And also nail care. Why nail care?
To prevent injury to the patient.
Patient will be rubbing, scratching that area, right? Because there will be itching, minor itching will be there. The patient will be scratching it. That will lead to what? Injury to the skin, right? So that scratching will lead to injury. So in order to avoid that, like we will cut the nail, the scratching will be not that forceful, right? So we have to provide nail care. That is, cutting of the nail is very important. That has to be considered whenever we are educating a patient or a caregiver in the home care setting, or even in the hospital. We know we are giving them head to toe care, everything, right? So in that, nail cutting is involved. But in the home, we cut it and we'll send them home. What will happen? The nails will grow, right? So what will happen? They will scratch it and it can lead to more worsening of the bed sore. So nail care is very important. That has to be educated to the caregiver, right? And there is a prevention strategies which we are following, that is SS skin. That is S skin. We can say S skin, double S skin, or S skin, right? So what is S? S is supporting surface. Supporting surface is what? That is, make your patient to get pressure relief on a particular supporting surface. That is, that we are providing assistive devices like air mattress, water mattresses and all, right? So that supporting surfaces has to be provided in order to prevent that prolonged pressure in that bony area. So we will be providing supportive surfaces. Then skin inspection. Why it is important, skin inspection? Please respond. Why skin inspection is important? To find out ulcer prone skin. Okay, Jyoti, thank you for responding. That's right. To find out the ulcer prone skin. Then to see any kind of
the stages of wound skin.
Okay, oh fine, very good. Then why we are inspecting a skin? Then whenever we take bath, we inspect our skin. Any kind of pimple, rashes are there or not? Do we do? Yes or no? We do it or not? Yes. Priyanka responded, yes, yes. Why we are inspecting it? To check whether any kind of abnormalities are there in the skin or not, right? So whenever there is a bedridden patient, if we are not, if like a patient is one day the what we can say, a caregiver who is more as assisting the client, right? He was not available for 4 or 5 hours. The patient was in a single position, right? So what will happen? When the next day the caregiver comes and change the position, he will be inspecting that skin area for any breakdown, any discoloration, right? Any kind of purple color or red color are there in the skin, in the bony area especially. So that has to be monitored. So skin inspection is very important. Supporting surface is important. Then skin inspection is important. That is regular inspecting the bony areas, because that area will be more prone to get bed sore, bony areas, right? So we have to check whether there is, or if there is a redness, never rub that area, because that rubbing will lead to second stage of ulcer, right? So never rub that area. We have to take extra care. Then around the area we can circulate, massage it, but at that red area, if you will touch it, that will become into second stage, right? So we have to inspect the area. That is very important. Then keep moving, that is changing in the position, as you have said, 2 to 3 hours duration, we have to change the position. Then I for incontinence and moisture control. This is very important. Either we can do it by catheterization or frequent changing the dressings and diapers, right? Then N for nutrition, that is protein rich diet, hydration, and also extra regular diet the patient should, because there are many bedridden patients who are not getting a regular diet, regular right diet, right? They will be eating a chapati or a rice, everything, but protein is not there. Then that diet is not that effective for that patient to heal that ulcer, right? Bed sore. So the regular diet we have to give, because one time only a day, in a single time they will be able to eat. Night time they will not get food, right? So that regularity has to be maintained, and right diet has to be followed, and also fluid intake we have to increase, so that dryness has to be prevented, right? So is it clear? Prevention, just remember by S skin, right? Double S skin or S skin, right? That is supporting service, skin inspection, keep moving, incontinence control or moisture control, and N for nutrition, right? Next is, this is also an important part, that is engage the patient and family. We have to engage the patient and family, because in our setting, palliative setting especially, we are considering the patient and also the family, that is especially the caregiver. So we have to involve the patient and family in pressure ulcer prevention. And also we have to develop a contract of care. Contract of care means, like today the patient has come to our hospital, we have identified that it's a stage 3 ulcer wound, bed sore is there in the patient, right? So what we can give is, we can make a 2 weeks duration contract. That 2 weeks duration, anybody's, hello? Okay. Okay, so we have to develop a contract of care, right? So we have to establish a contract, that is a duration in which we have to work together with the patient and the caregiver in order to prevent that, or in order to promote the healing of the bed sore, right? And also what can we do together to prevent pressure ulcer? So we can also involve the family members. We can identify what are the hindrances which are preventing that bed sore to be healed up, right? Either it can be related to money matter, that is the financially he is not sound to get the proteins available for them, right? Protein rich diets available for them. So we can work together, because in the palliative setting we are not dealing with the physical ability of the patient, we are dealing with the physical, social, spiritual, socio-economical, every 4 aspects are a health, right? So we are dealing with that. So we have to consider the family also, and we have to find out the ways in order to work together to prevent the pressure ulcers, and also prevent information leaflet. We can provide information leaflet to the patient, so that when we are telling, either like we are providing 100% education, but what happens, only 80 or 70% will be written in the head. So we can provide a book of leaflet, so that will be readable, or that can be he heard, or any kind of that, so that leaflet will help them to remember that points and prevent the occurrence of the bed sore, right? So this engagement is very important with the patient and the family and the healthcare provider, right? So this is an image which is shown in Malayalam language. But as you can see, the patient is lying in a supine position, sideline position. First, the patient was in the right side, then left side. So these are the images, or what we said about the leaflet, which we have to consider giving to the patient and the caregiver so that they can follow that instructions, right? So you can also make yourself a single pointed thing and you can give, especially a skin that can be given. You have to write in a dramatic, graphical way, and you have to give it to the patient and the caregiver so that they can follow at the home setting, right? So this was the session. Hope you understand what do you mean by wound, how the bed sore develops, what is the pathophysiology involved in that, what are the risk factors which has to be mainly considered to prevent the bed sore, how to manage it and how to prevent it. Okay. Hope the stages of bed sore is clear. That is very important. Very important thing considered whenever you are in a nursing setting or wherever you go. Right. So in our field, it is very important to understand how to prevent the bed sore and how to manage it when it comes to our hand. So whatever I know in your setting, you will be more familiar with the wounds because you are regularly seeing that wound, right? So how to manage it, how to prevent it, if foul smelling is there, how to deal with that. And also we have to, especially we have to talk to the patient. So if there is a wound which is mainly what we can say, a wound which is not, we'll come to the fungating wound next class, but still a wound which is making the patient's appearance very much impaired, right? So what will be happen? Body image disturbance will be there though. So we can talk to the patient for a while to ventilate their feeling. That is very important. That ventilation of feeling will be helpful to understand the patient, what are the problems they are facing it, right? So this is it. So we will be looking into a video.
Thank you, Snehalatha, for the wonderful session. Anybody have any doubts on this? Please ask her. Any doubts? So I saw one question in the chat box. How do we assess tunneling? Anybody would like to answer for that question? So from today's class, we understand that the proper assessment is mandatory for better management. So if there is any tunneling there, we have to identify whether there is a tunneling present or not. If there is a tunneling there, you have to give a special attention on that point. Otherwise, that wound won't be healed properly. So we need to find out whether the wound is having tunneling or not. So how do you assess tunneling? How do you assess the length of the tunneling and all? Any idea?
We can
We
use
all
the
nurses.
culture swabs. We can use the culture swabs and we can able to measure it.
Okay, thank you. So yeah, as you said, you can use cotton tip applicator or a swab sticks for assessing tunneling. Okay, thank you. Any other questions?
Okay, I would like to add one point. In the image, we have shown it. Have you seen that image of tunneling? I have shown it again, second time. Have you seen it? So what was the material which is used when we are seeing that tunneling? It was a kind of stick, as Java said. It can be a swab, or when we will be using artery also, right? So that artery's length can also be measured with the tape. So that will also can identify that that tunneling is how much length it is going inside, right? So that way also we can. I think I'm right, right, ma'am. We can.
Yeah, yes. If you yes, if you are using artery forceps, you have to cover the tip with a gauze piece. So otherwise the tip will
Shiva ma'am?
cause injury. So if you are, can you hear me?
Yeah, ma'am.
Yeah, so if you are using active forces, if you don't have a cotton applicator or soap sticks readily available, then you can use your own active forces, but you have to cover the tip with the gauze piece. Thank you. So if you don't have any questions, we can move on to the case presentation part. Ms. Sindhu will be presenting a patient story. Mr. Sindhu, is over to you.
Sister Sindhu?
Yes, ma'am. Case presentation about traumatic spinal cord injury to spastic paraplegia or pressure sore. Then patient age 26 years, gender male. Presenting complaints, weakness of both lower limbs, having impairment of lower chest and abdomen, loss of bowel and bladder control, pressure sore, activity limitation. History of illness. Patient has an lead history of road traffic accident, bike versus bike, well hitting back, wound on left side of the head and had loss of consciousness, wound featured, regained consciousness after 2 days, D5, D6 laminectomy done, D4, D5, D6, D7, D8 fixation and cord decompression done after 10 days. Discharged after 3 weeks. On examination, patient conscious and oriented, body weight 60 kg, vital signs at the normal limit, BP 110/70, pulse 68 per minute, respiration 16 per minute, temperature 98.6 degree Fahrenheit. Treatment and significant investigation, routine investigation, hemoglobin 10.4, rest normal, treatment daily dressing, pressure sore, laxatives, vitamins, antibiotics, CPR, BP, IO chart, SCA rehab program, continuous bladder drainage. Psychological aspects. His family is his mother and sister. He is the only earning member of his family. Owns a Paka house 50 meters away from the road, bathroom unattached, no source of income. Takes financial support from his friends. He is mentally disturbed about his movement limitation and worried about his aged mother. Medications have vitamin C, OD, multivitamin, OD, tapped alcohol is 2 Hs, capsule Lumia once in a week, tab augmentin 658 hourly, tab methoxy 400 mg, 1/8 hourly. Main concern, weakness of lower limbs, movement limitation, altered skin integrity, altered bowel and bladder sensation, financial problem, psychological problem. A patient 25 years old with a history of RTA, laminectomy, and cord decompression done. Now he is admitted in physical medicine department of government medical college Trivandrum. Chief complaints are weakness of both lower limbs, altered bowel and bladder sensation, pressure sore. His treatment is for wound healing, bowel and bladder emptying, draining of activities of daily living. Discussion point. We need to provide palliative care for this patient. What are the problems faced by this patient? What can be done for the rehabilitation of the patient?
Thank you, Sister Sindhu, for the presentation. Anybody need any more clarification regarding this patient story? Please ask her. Otherwise, we can move on to the discussion points. So I hope this presentation is clear to everyone. So we can move on to the discussion points. So Sister Sindhu Mol is asking, do we need to provide palliative care for these patients? What do you think? Please respond. Yes. Yes. Okay. So thank you. Thank you for your response. Definitely, this patient needs palliative care because this patient is having a life-limiting illness because paraplegia. Then he is worried about his mobility. So definitely, this patient needs palliative care. The next question is, what are the problems faced by this patient? So just think about a 25-year-old man suffering with a paraplegia, maybe met with an accident and followed by paraplegia, lot of problems. So you have to think about the four aspects. What are the physical problems? What are the psychological problems? What are the social and spiritual problems he might develop? Just share your thoughts. Sneha, over to you.
Has responded psychological issues. Hema Padmaji has responded immobility dependent bed sore. Yeah, okay. Any other responses? So he is facing problem related to four aspects. What are the four aspects? Physical disability make a frustrating during the young man. Yes, very true. Physical disability is very frustrating to the young man. He's just a 25-year-old man. Then immobility because he's having a fracture. So that physical disability, that immobility is also a factor. Psychological issue because because that 25-year-old man mainly he has to be roaming outside, right? The home. He will be doing his job and all. So that is impossible in this condition. So he will be psychologically depressed also. Then socially also he will not be interacting that much the way he used to interact with the friends and all. So he will be socially, he will be completely isolating himself from that social gatherings and all because he's bedridden, right? Then and he will be spiritually also he will be down. He will be cursing the god that why I have these problems, right? So these all can also a problem that can lead to more frustrating. So these are the problems that the patient will be facing. Pain could also be problem. So pain management. Very good. Yes, Stella. Yeah, pain is also a factor that will be more psychologically he will be facing that pain. We have to manage the pain and also without an income managing the medication and daily basics. Very good. Yeah, without income he will not be able to manage his normal daily activities. Yeah, and he will not be getting proper diet also, right? So that nutrition also can lead to a bed sore, right? Then improper available nutritions. Then so we have touched all the four aspects. That is the physical. He will be physically down because he is unable to move his extremities, lower extremities. He will not be able to walk by himself. Okay. And he will be having pain. Pain is also a cause. Disability is also a cause. He will be getting psychological issues with that because that frustrating, always confined to a bed and not doing anything can also lead to that frustrating situation, right? So these are the problem he can face. And what can be done for the rehabilitation of the patient? For the pain, we can give pain management. For the immobility, we can deal with the patient. We can provide range of motion exercises by literally moving. Then we can go into the physiotherapy consultation and look into the matters that he will be able to. Yes, Ashwati, very good. Physiotherapy, bed sore management, that is, we can make a contract and do a dressing in a sequential manner, and we can provide them education, diet, everything, and we can overcome that problems, right? Then what rehabilitation we can do? Physiotherapy, yes, of course we can do. Then we can provide them range of motion exercises. Then when the patient will be in a normal uh, we can give psychological support also. Yes, very good, because he is frustrated, so we can provide them psychological counseling. Yeah, we can provide them counseling also. We can provide them, because nowadays in the rehabilitation, if a patient is a wheelchair, we can provide them wheelchair friendly environment, right? So that they can do their activities by themselves. Vocational therapy, yes, very good, Hema ji. Vocational therapy we can give to the patient, yeah, like when he will be recovered from that condition, when he is able to sit by himself in a wheelchair, we can provide them recreational therapy. Mind diversional therapy, initially we can tell them to follow, so that he can either read the book or he can color a drawing. So these all therapies will be helpful to divert the mind and take the patient into a normal daily living style, right? So not as the earlier state, but now with that situation, he will be able to deal with the upcoming hurdles of life, right? Yeah. Okay, I hope all the point has been covered. And I would like to ask Sindhu Mol Vijayama, who have presented the case, that how you manage this patient in your facility. And what was the stage of pressure sore the patient was having?
At that time, it is stage 3. Now it is turned to stage 1.
So now it is recovered and stage 1. Okay, what all management, like beds or dressing, what kind of dressing you have used it?
First time, metrozil dressing is given from initial stage. Now it is turned to mega heal.
Okay. Okay, any other like aspects you have, like physical, doing beds or everything, then psychologically how you maintain that patient, because he was only 25-year-old.
Yeah, he's every day, all staff in duty visit him and talk to him about his condition and give psychological support to him, and ask him to talk with other patients who is admitted in this department. Now he is able to make umbrellas for sale. So he is given a training to make umbrellas, and it will support his financial status. And also he is changed from bed to wheelchair. Now he can manage he can use wheelchair to travel from ward to physiotherapy home.
Okay. Okay, thank you.
Thank you, ma'am.
Okay, hope you would have understood how this case has been managed. Though we have read the case, we know that the patient needs a palliative care support. The problem he faced, we have to touch the 4 aspects. All aspects has to be covered in order to maintain that patient as a single being, right? And also the rehabilitation, like he is making umbrellas now. So the rehabilitation means what? Restoring the life to a normal living that he used to do earlier, but not in that way, but the way he can do now forward, right? So that rehabilitation services we have to provide the patient, so that he doesn't have a feeling that he is now a burden to everyone. So he can do many things, right? So this is it. Shiba ma'am.
Yeah. So, Jeba, do you want to ask anything or add
Yeah,
anything?
yeah, good day, ma'am. Recently, I saw one 42 years male patient. He is a polio attack male guy. Um, So, 3 days, last 5 days back, I saw the patient that pressure ulcer is stage 4. Around 7 wounds is there. So I have measured that tunnel length also. It's around 3 centimeter, 3 centimeter each wounds. So I spoke with the GP. He said to start the augmentin 1.2 gram BD. So today morning only I have started. The dressing is done by nearby one OT technicians. I don't know exactly who is that. So whether I have to change the dressing pattern or not. Excuse me.
Yeah. So anybody wants to answer this question? Any volunteer? So I would like to ask one question. Why do you use glycerin myself for this wound? So
Because
yeah, so I would like to know from you. Is there any doctor suggestion or the OT technicians himself do the glycerin max self dressing? He does or he
no
does
idea.
it
Maybe
his own? No idea.
yes,
So
because
yeah,
exactly before 5 days only I saw that patient. Immediately within a day, I have sent the cultures from 3 sites I have taken. The reports are hardly heavy infection. I got it.
okay. So yeah, did you get the report?
Yeah, it's in my hand.
Okay. Yeah, okay. So based on the report, you can give an
Start.
antibiotic for that,
Yes,
definitely.
injection augmentin.
Yeah,
I forwarded the
okay.
report to GP
Good.
also. He said to start augmentin only. But the patient is
Okay.
very malnutrition.
Yeah. So
Weight also around
as
48.
yeah. So you have to think about the nutrition part also, because definitely we need to heal this wound, and also you have to prevent the further deterioration, because we have to prevent the further pressure ulcer formation. At the same time, you have to think about whether there is any role of glycerin maxilf. If you use glycerin maxilf in the fresh wound, what happen? So there will be a irritation, and that will destroy the granulation tissues. So better you can use metronidazole tablet, crushed and make it a powdered form and apply, mix with the Vaseline or white petroleum jelly, and apply on that part. And if that, yes, tunneling part, and then so you just leave the wound one day, and then every alternate day you have to clean it, do the dressing. And also, if the metronidazole is not helpful, if the wound is having that necrotic tissues, like black necrotic tissues there,
I
then you
think no
can
need for debridement.
debridement. No
No
necrotic
need.
tissue.
Yes.
No. Okay. So then you can use metronidazole, and also you can think about McGahee ointment. So
Actually,
this will be helpful.
I got a history from the patient. He's saying that OT techniques frequently using the betadine.
Betadine, yeah. So usually the betadine is one of the hypochlorite solution. This will destroy the granulation tissues. So
Yes.
please tell them don't use betadine. They can clean his wound with the normal saline. So normal saline is enough to clean that wound.
Okay, the normal saline one day is dressing. Next day we have to leave it like that.
Next day, yes. Then every alternate day you can give adequate time to heal that wound.
Thank you. Thank you so much, ma'am.
Okay, so then if you need any help, you can call me. You
Yeah,
can take
sure,
my
ma'am.
number from Senior or Sripriya, then you can call me. So I will try to answer
you.
it. So I'll
Thank you.
give an idea. Okay, so coming to this patient part again. So 25-year-old man met with an accident followed by paraplegia. We have discussed about his conditions. So Snehalatha had discussed about the physical part, social part, psychological part, and spiritual part. So there are a lot of physical problems, especially bed sore. So I'm happy to hear that that is healing stage. And this patient is on a Foley's catheter. So you have to think about the continuous intermittent catheterization. So if there is a blood, only 25-year-old man, no, you have to think about that. If there is a bladder sensation there, you have to teach the patient about how to put a catheter, the nail cath his own. So you have to educate the patient about the same, so that we can able to reduce the urinary tract infection. Okay, and next thing is you have to prevent the further pressure ulcer formation. Okay. And this patient is also having financial constraints, so maybe lack of nutrition is also as the other risk factors. We have to think about the food kit, whether we need to give a food kit or not. So if they really need a food kit, you have to connect with a local palliative care unit or NGO who is willing to help these kind of persons, so that they will get a good nutrition support. And also from that patient part, you have to think about the physical rehabilitation, vocational rehabilitation part. So because physical rehabilitation, this patient is bedbound, you have to give proper physiotherapy, and if there is any role to revert, definitely we have to try for that, because at least he can able to get up from the bed to wheelchair without support. So that part we have to make them independent. So that he can able to move independently. Even if he is in wheelchair, also he is able to move independently. So that part you have to think about that. And then uh, air mattress or water mattress. These all comes under in physical rehabilitation. And vocational rehabilitation, his lower part is not able to move, but his upper limb is able to move and able to work. You have to think about the vocational rehabilitation, like one of you said earlier, umbrella making or computer typing, anything. So you have, based on his interest, you have to talk to him and understand his concern and understand his emotions and his ideas about the occupational rehabilitation. And based on his willingness, you have to educate them and educate him and empower him and connect with the local volunteers, and so that he can able to get some kind of financial help from the occasional rehabilitation. So these kind of things you have to look into. And coming to the spiritual part, he's not able to move out. So uh, I that so one slide, his friends is helping financially. So you have to talk, if possible, you can talk to the talk to his friends, and yeah, at least he can able to go out on at least a day. So whether they maybe if he's a Hindu, you can maybe one day he can able to go to the temple. If there is a Christian person, they can go to the church with the support of his friends. You can talk to the friends, and
Sure.
also you have to connect with the community, and so that we can able to help this person totally. So definitely, if you think about the four aspects, if you give, if you try to cover the 4 aspects, definitely we can able to improve the quality of life so as much as we can. And as one more question I would like to know from you, did he know the prognosis?
Not fully, ma'am, but almost informed.
Not informed. So the hope will be there all the time. So whenever I have seen many patients like this, so wherever we go to this patient, this kind of patient side, so they will be asking, so when I am able to walk, so is there any improvement? These kind of questions will be there. So make them understand that. But now we learned how to communicate the bad news step by step. So you have, if he really wants to know the prognosis, definitely you have to tell him very sensitively. So step by step you have to break. So that he can able to cope this problems, and he will try to overcome, and try to manage his own power and all. So definitely the breaking bad news, he needs to understand the prognosis, but not in a certain. You have to, if he is willing to hear his prognosis, definitely you have to break the bad news as a step by step, like a spice protocol.
Sure, ma'am.
Okay, and financially, he is the only 1%, the earning member of the family. The family members also affecting because of his loss of that financial support from his he is not able to work anymore. So because you have to talk to his family also, and is there any role of vocational rehabilitation? These kind of things you have to think from the family side also.
Sure.
So any points anybody wants to add? Any points? No. So I hope this session is clear to everyone. So whenever you have seen a bedbound patients, you have to think about the double SKIN. Okay. So Sneha has explained very well about the double SKIN. So if you think about these words, definitely, I am sure you won't miss anything. So you have to think about that, and always you have to try to engage the patient family. So because without patient family support, we can't do anything. So this is a bedbound patient. He needs total family support. So you have to empower the patient family members for preventing pressure ulcers. That's also important. Instead of you, we always use the term you. You should do like this. You should change the position. You should do the proper dressing. You should give that massage. You should provide a wrinkle-free bed. That kind of things we usually do. But what we suggest is, instead of you can use the term we. So what we can do together. So we, if we use the term we, so they might be thinking, okay, we are all with them, and they will, somebody is begging them to help them. So that kind of things will be there. You can start the word, use the word we instead of you. Okay, and also you can think about the leaflets. Okay. I think no questions. We can wind up today's session. Thank you, Snehalatha, for the wonderful session. And thank you, Sister Sindhamol, for the wonderful patient story. Thank you, others, for your contributions and suggestions. Thank you.
Thank you, Snehalatha sister, for joining us. I know that your duty is not over it and you are rushing back. You will be rushing back to your work in the setting. Still, you found out time and you enlightened us with the topic. Thank you so much. And it is indeed our pleasure to be having Sister Sindhumur, who I just got the information that was awarded with the Nursing Excellence Award from Kerala State this year. So it was really nice knowing you, Sister Sindhumur, and we hope that we are fortunate to have people like you coming to us and learning palliative care from us. Thank you so much. Thank you everyone for joining in, and with the promise that we will see again in the next session with another eminent faculty. This is Sri Priya along with Sister Snehalatha and Sister Shiva signing off from the Tipsy Co. Till we connect again, stay happy, keep spreading happiness. Bye bye.
Thank you.